and welcome to the ACR Journals on Air podcast. One of the cases I remember vividly from my training was looking after a young woman with antiphospholipid syndrome who was both clotting and bleeding at the same time. At that time, we had very few options for treatment, but I'm pleased to report that in 25 years, things have changed immensely. The manuscript we will discuss today is Antiphospholipid Syndrome, an antibody-mediated disease with emerging therapeutic opportunities. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. I'm excited to be joined by the senior author, Dr. Jason Knight. Dr. Knight is the Marvin and Betty Danto Research Professor of Connective Tissue Research at the University of Michigan. Dr. Knight received his MD and PhD degrees from the University of Michigan, and his fellowship in rheumatology was at the University of Michigan, where he pursued postdoctoral research in the laboratory of Dr. Mariana Kaplan, someone who we've had on this show previously. During his fellowship, Dr. Knight received the prestigious American College of Rheumatology Distinguished Fellow Award, as well as a Rheumatology Research Foundation Scientist Development Award. Dr. Knight's research to better understand triggers and effectors of autoimmunity in lupus and antiphospholipid syndrome has been supported by the NIH, the Burroughs Wellcome Fund, and the Department of Defense, the Lupus Research Alliance, and the Rheumatology Research Foundation. He's received numerous awards for his work, including the Jerome W. Kahn Award for Excellence in Research by the Department of Internal Medicine, the Edmund Du Bois Award for young lupus researchers from the American College of Rheumatology, and the Mary Betty Stevens Young Investigator Prize from the Lupus Foundation of America. He's also a member of the American Society for Clinical Investigation. Welcome to the show, Jason.
Thank you, Vicki. I'm very happy to be here and excited to talk about APS, which is one of maybe my favorite topic to cover.
Oh, it's a pleasure to have you. You start your article with a case. I wondered if you could tell us about that patient.
Yeah, I certainly can. This is a patient from my clinic, though, and to the reader, it may seem like it's still too complicated, but we did try to simplify it a bit, which the editors kept pushing me to do more and more, but I'll give you the short version. So as the case was presented, she's a 37-year-old female coming to your clinic with difficult APS and needing some next steps in management. Her story goes back to age 19 when she had a DVT. At that time, she was on an oral birth control pill, and the event was not further investigated. It was felt that was enough explanation. She did a short course of anticoagulation and then went back to her normal life. She did well for a decade, but then at age 31, she developed inflammatory joint pain, the kind of thing you could have seen in someone with lupus, although she has never acquired that full diagnosis. She was seen by a rheumatologist who found her to be antiphospholipid antibody positive, to have a little bit of an elevated SED rate, and then not much else. So it was thought maybe this was kind of a lupus variant, and she was started on hydroxychloroquine. It was also recommended that she take an aspirin daily. She did well for about a year, but then more bad things started happening. At age 32, she presented with acute abdominal pain after an influenza-like episode and was found to have colonic ischemia, and this ultimately turned into a diagnosis of catastrophic APS, which we also call CAPS. She recovered from that and was treated appropriately in the hospital with our typical triple therapies such as heparin, corticosteroids, and plasmapheresis. And now she was discharged on warfarin. So now she kind of has the full armamentarium of antiphospholipid treatments being brought to bear. And things did stabilize for a few years, but again at age 37, and so this is leading into the referral, she developed shortness of breath, was treated for infections, and that didn't help. It was eventually diagnosed with diffuse alveolar hemorrhage, which in APS can sometimes have more of a smoldering course, not always diagnosed in the inpatient hospital. And so that's the question. We have this patient who's seemingly on the right meds for APS, but is still having problems, and what to do next. And so we circled back to the case at the end of the article, and I'm happy to hang back on the rest of the story for now, if that's what you want.
It's great. It's a not uncommon presentation, and thank you for kind of sharing this patient's story. Let's talk a little bit now about antiphospholipid antibodies, because obviously they're not just biomarkers, they're also pathogenic. In figure 1 in your manuscript, you have a graphic that's trying to connect the clinical features and the antibodies. Could you explain that for our listeners?
Yeah, and it's kind of a simple graphic, though it's a little hard to fully paint the picture with words, at least for me. It's a concept that I took from Robert Ruby, who's a rheumatologist at University of North Carolina. He gave me permission to show this adapted graphic in my talks and also for this manuscript. But he's just trying to help us understand, like, what's the difference between a lab test versus what the antibodies actually target, like what's the true autoantigen, and then the clinical associations. And I don't think we have to go through all of it, but lupus anticoagulant can kind of be taken as an example. Sometimes people talk about lupus anticoagulant like it is a specific antibody, which is not the case. It's a functional assay that we use to screen for high levels of antiphospholipid antibodies in the blood. I mean, that's my pet theory as to why it often brings the best specificity of any of the tests, and that's because it takes a lot of antibody to turn the lupus anticoagulant positive. So, low key, it's also a readout on how much antibody the person has.
Mm-hmm.
But we know that anti-beta 2 glycoprotein antibodies can turn that test positive. That's a classic that we'll probably talk more about. But also anti-prothrombin antibodies, something that we don't routinely test for in APS, but seem to be part of the picture. And so under that umbrella of lupus anticoagulant, we have, multiple autoantigens that could be at play. And as mentioned, this does turn out to be a relatively specific test for APS. So if you find someone with lupus anticoagulant, that's not something we commonly find, in someone who's just post-infection, but tends to point more specifically to APS.
Yeah, great. And since you brought it up, let's talk a little bit about beta-2 glycoprotein 1.
Yeah.
This is one of the plasma proteins that people are developing antibodies to. It's an interesting molecule with some essential functions. Can you tell us a little bit more about it?
Yeah, it is interesting, although it's yet another kind of challenging name that we have in this field. The other name for beta 2 glycoprotein 1 is apolipoprotein H, so a similar big mouthful. As you mentioned, it is a plasma protein, and one of the things it's good at is binding phospholipids. It seems to have a special affinity for negatively charged surfaces. So negatively charged phospholipids work well. Something that our group and a few others have been working on recently is that it also seems to be good at binding DNA, which we can sometimes find in inflammatory environments. And we may talk a little more about that as we go here. So yeah, things I remind people about is that it's a relatively common protein in plasma. Its functions are still a little bit obscure. For example, we can knock it out in mice, and if we're not stressing the mice, there's no obvious phenotype. I tend to think that it probably has some redundant scavenging functions. So under stress, it may help us clear LPS from the blood. That's one idea that's out there. It may help us kind of tag and clear apoptotic cells, which have negatively charged phospholipids on their surface. So it's a protein that we do get autoantibodies to sometimes that has a function that we maybe don't totally need, but here we are for now.
So, well, that brings me to my next question, which is, what do we know about why do some people form antibodies to beta-2 glycoprotein 1, and yet others don't get any antibodies at all?
Well, and yeah, this would not be the only place in rheumatology that I think we don't have a perfect answer to that question. I mean, for beta-2 glycoprotein, there's a few ideas. I think, because I looked to see what we wrote in the article, and we wrote this. Several potentially overlapping mechanisms may play a role. So, yeah, when you read something like that in a review article, that means we don't totally know yet. We go on to spill some more words. I mean, we talk about that it's been occasionally recognized that there are missense mutations in the genes that change specific amino acids. And this doesn't seem to be the prevailing cause, but in some of those folks, there does seem to be that seems to unlock a propensity to autoantibody formation. A second factor that's been raised is oxidative stress. There is one dynamic disulfide bond in beta 2 glycoprotein, and when that's oxidized, it seems to make beta 2 a better binder of surfaces. And I could have mentioned this before, but I think I do like to emphasize this point that, in lupus, we think about immune complexes like circulating in the bloodstream. And in APS, it seems to be more of a surface complex that forms on a cell surface, not a free immune complex. And I think a reason for that is the affinity of these antibodies is not as good as for some autoantibodies. And so not as good means not as strong as for some other autoantibodies. And so it may be that that antibody needs to grab onto a beta 2 molecule with each of its arms. Like only when it has two connections can it really hang on and stay engaged on the surface. And so, under times of stress, that's when we probably find more beta 2 glycoprotein on cell surfaces, and that creates a platform for these antibodies to find.
Yeah, that would make sense. What do we know about the different isotypes of these antibodies in clinical practice? We do test the isotypes, the IgG, the IgA, the IgM. Does it matter? Are some more pathogenic than others?
Well, kind of a joke, but if it didn't matter at all, then why are we sending this testing? I just sometimes point out that this seems to be a little unique to APS versus other things we see in the rheumatology clinic. We're not routinely getting anti-CCP data for all three of IgG, IgA, and IgM. When there's confusing aspects of APS, I've tried to go into the history. So things like lupus anticoagulant, I feel I made peace with and stopped feeling kind of annoyed with that test once I understood the history better. But for isotypes, I still haven't totally figured it out. So IgG antibodies are clearly pathogenic. We have many years of work in the laboratory to show that you can isolate these antibodies. You can put them into mice and cause blood clots to form there. You can treat endothelial cells or neutrophils in the test tube and activate them. Like these are clearly a pathogenic antibody. IgM got deprioritized in the most recent classification criteria. And actually, if IgM is all you find, we're not supposed to classify someone as APS nowadays. You don't acquire enough points. And I think that was partly, put in there as a call to action for researchers. Like we need to do better at understanding these other isotypes and what they really mean.
So what do you do in your practice? Do you test all three?
Well, I'm a rheumatologist, so I send as much testing as I can.
So I've always wondered why, as in the case of the patient you present, some patients will have a thrombotic event long before any other systemic manifestations of autoimmunity. There's a complex web of science, some of which has been unraveled in your lab, that might well explain this syndrome of someone first presenting with primary antiphospholipid syndrome and later developing manifestations of lupus or other systemic autoimmune disease. Tell us about these findings and how may they explain this long recognized phenomena?
Yeah, that's a nuanced and smart question, in my opinion, though you're preaching to the choir a little bit here. You're right that when we diagnose primary APS, I sometimes coach patients that there's a 10 to 20% risk. I mean, maybe 10% is a better number that over time, this could develop into a full-blown lupus syndrome where that diagnosis would also be available or would also be appropriate, I should have said. We certainly diagnose lupus and APS in the same person, but I'm talking about, as you described it, the person that starts out as APS and then seems to evolve into something else. We saw that a little bit with the case I presented, where it seemed simpler at the beginning and there seemed to be more features of autoimmunity that were accruing. I mean, one topic we have been studying is the role of neutrophil extracellular traps or nets. These are structures I learned about from Mariana Kaplan when I was a fellow. Yeah, soon it'll be 15 years ago, working in her laboratory at Michigan. And these are structures with lots of autoantigens in them, including DNA, which is the backbone of the net. And so, and an important point is that, when a cell dies by apoptosis, that's an anti-inflammatory way for the cell to die. But when it dies by netosis, releasing a net, this is a very pro-inflammatory thing to happen. And so now all of these autoantigens are intermixed with pro-inflammatory factors that are likely to turn on the immune system versus shutting it down. And so I think these are the types of platforms that could lead to, antigen spread, if you will. One topic that we've been working on, and this has been especially led by Ray Zhu at University of Michigan. I think he did this podcast a couple years ago,
He did.
talking about some of his work and did a very good job, as I recall. So, yeah, what Ray has been interested in is anti-net antibodies. And so right now we're still thinking of it as a more holistic readout. We make nets from human neutrophils and put those into plates and ask if there's reactivity to them. And there's a subgroup of people with APS where, in addition to the antiphospholipid antibodies, we now find this activity. It's likely that part of that activity is driven by an anti-DNA response. And so you could imagine how we may begin to spread from a more clean antiphospholipid syndrome picture to now more promiscuity in terms of the autoantigens that our antibodies are recognizing. So
Yeah,
I think
so
that's part of the story, not the only one, but probably
and then
part.
antibodies beget antibodies, maybe that one thing kind of snowballs and leads.
Yeah, I think so. Well, yeah, as I was walking through that, I mean, a key part is that we know antiphospholipid antibodies are good at triggering nets. So it is a
Mhm.
pro-net environment. And as mentioned before, beta 2 glycoprotein, classically described as this phospholipid binding factor, but it can also certainly find its way into the nets. And yeah, I think these are interesting platforms where we may see that spread and broadening of autoimmunity.
So you actually kind of put this into a brilliant figure in your manuscript where you're trying to explain how antibodies ultimately trigger thrombotic events and inflammation. Is that something you could put into words for our listeners?
Yeah, not as perfectly as the figure does it, and thanks for calling it brilliant. This was done, yeah, mostly done by the graduate student Talia Newman, who's just a great immunology student who, yeah, I wrote this review with, and I, yeah, asked her to take a fresh look at the anti-beta 2 literature to help us understand where it fits in APS pathogenesis. And so one thing she illustrated was the different co-receptors that we think these beta 2, anti-beta 2 complexes on the cell surface may signal through. Definitely toll-like receptors can play this role in some contexts, including in neutrophils based on our work. There's another set of receptors called LRP receptors or low density lipoprotein receptor related proteins. But these are a little bit like scavenger receptors. They can turn on some MAP kinase signaling. And so that tends to be a theme. There's co-receptors that activate classical pro-inflammatory signaling, whether it's MAP kinases or NF-kappa B, and that's what leads to cell activation. In the second part of the figure, then, we tried to show the scope of the cells that we think are involved in APS. And we can talk about this when it comes to treatment, but I think this complicates treatment a little bit if we want the precision because, our lab and now others have shown that there's good evidence that they activate neutrophils. These nets are also very prothrombotic when they're released intravascularly, where I don't think they're supposed to be released normally, but it does happen in APS. But also monocytes get turned on, platelets certainly get turned on. We know the endothelium can be turned on, especially under stress in animal models. You can see that after injecting something like LPS, suddenly beta 2 glycoprotein is finding the endothelium everywhere. It had been happily circulating through the bloodstream, but now is being attracted to the endothelium. So these are all different cell types that get turned on, and it seems to be that combination that brings the APS phenotype. It's certainly possible that in individual people, their particular autoantibody milieu leads to some of those cells being emphasized more than the others. And I mean, I think that's a potential opportunity for more precise treatments. But you can imagine these are cells that, our immunosuppressants are not, these aren't the T cells that are, immunosuppressants are best at targeting. And so, I think it points to some complexity and how we still haven't settled on more precise treatments than simply prescribing blood thinners. That's
Yeah.
my elevator pitch. It's an autoimmune condition. We are still treating with blood thinners. We can surely do better than that.
I love it. I agree with you. So let's spend a few minutes discussing treatment. Anticoagulation obviously is essential for people who've had thrombosis, but the choice of anticoagulation matters. What's the current evidence?
Yeah, and that's a good point that I think is starting to be recognized pretty broadly, but it's good to restate it here if someone's while doing their exercise regimen, they can be reminded of the best way to treat APS. So, I mean, the short version is we still seem to be stuck with the classic drug called warfarin, which is a vitamin K antagonist, leads to depletion of certain vitamin K dependent clotting factors, specifically 2, 7, 9, and 10. And so the problem is newer agents came around, which I guess is a group we call direct oral anticoagulants or DOACs. These are agents like rivaroxaban, also known as Xarelto, or apixaban, also known as Eliquis. And when those have been tested side by side with warfarin in APS patients, more breakthrough strokes were seen. That's the short
Mhm.
version. It wasn't as strong in an effect in every study. The study that showed the strongest effect, the most damning evidence against DOACs, if you will, was limited to triple positive patients. So, triple positive means that all three of the classic antiphospholipid antibody tests are positive. And, I think as I was hinting above or before when I was talking about lupus anticoagulant, I think more antibody burden is definitely a risk factor for worse disease. So there seems to be something about warfarin that is helping the arterial side of the circulation in a way that these DOACs are not. I do not believe that we will never be able to recommend DOACs to our APS patients. I think there is surely a subgroup that could do okay on these meds.
Mhm.
But right now, we're just not smart enough about it. So, our default, I think, should be to try to get the patient on warfarin. And if, there's a legitimate reason they can't, then we have to talk through it and make sure folks understand that these other agents are almost surely better than nothing, but may not give as full a protection as warfarin gives.
Right. I think that's really important kind of to remember. What about adjunctive agents? You talked about the patient you presented and mentioned hydroxychloroquine, aspirin. What about other agents like clopidogrel, statins in these cases?
Yeah, I think everything you mentioned can have a role in some settings. I sometimes meet a patient with APS, had a venous thrombosis, not complicated. They may not have the highest risk profile if we look at their antibodies, and warfarin may be all that that person needs. We start to bring other agents to bear. One time we do that is when things aren't going well, and that's frustrating because it shows us being reactive instead of
Mhm.
proactive in our decisions. But better to react than not to react if those are our only two choices. So, someone has a breakthrough thrombotic event, if you will, despite being on warfarin, then adding aspirin is something that we often do. If you can find a reason to get your patient on a statin, these have nice anti-inflammatory properties, are probably very good for the endothelium. It's not something that we would start everyone on, but I certainly look for reasons to try to get people on those if they have another indication. Or in a refractory case, it's something you would think about. Hydroxychloroquine is something that we're using more and more. We still don't have a definitive randomized study, but there's retrospective data that look pretty appealing. Hydroxychloroquine has some antithrombotic properties in its own right, but doesn't seem to, increase bleeding risk. So, the same way we coach our patients that we don't think it's very immunosuppressive. So at least that part of taking the drug is, relatively free, if you will. I think we could say the same thing about giving us some help with preventing blood clots without increasing the risk of bleeding. So those are all agents that we commonly bring to bear. I guess one time we might use an antiplatelet agent more preemptively is in the person that's had an arterial event, whether a stroke or maybe an intra-abdominal arterial event, something else like that. I think it's a little bit based on feel more than evidence, but we just know what a good track record antiplatelet agents have on the arterial side of the circulation. And the stakes are obviously really high there as well. The next stroke is not one that you want to have. And so after talking with patients and explaining that we do have to admit the bleeding risk goes up at least a few ticks when we use that combo, we think the downsides are outweighed by the upsides in select patients.
So tell us a little bit about what might be coming down the pike now that we have some understanding of the thromboinflammatory cascade that's contributing to some of the clinical manifestations. What are the new therapies that are being considered, and what active clinical trials and new agents are being studied?
Yeah, I like that question a lot, and it's what motivated me to work on this article in collaboration with Talia. And I like that you use the term thromboinflammatory. I don't know that it's only me, but I've definitely been trying to work that into the APS literature more, and I think it's kind of found a home there. So it's a term that I like. But yeah, the hook of the article was that are we about to enter an era where we're going to have more kinds of options for our patients? I get a little daunted when I think about the heterogeneity of the effector functions that are being driven by the antiphospholipid antibodies, neutrophils plus platelets plus endothelial cells. How are we going to find a single agent that reins all of this in? And so that's when I make the point that what if we could just go to the source? We think, as you started things by saying these antibodies are not just, diagnostic markers, but are actually pathogenic. And so reasons if we could cure the antibodies, make them go away, then we might consider the person cured.
Hmm.
And so, what I think is exciting, and I mean, if you were at the ACR meeting last year, you certainly heard a lot about, cellular therapies and other types of therapies going after other types of B cell antigens, such as CD19, plasma cell antigens like CD38 or BCMA. I think the question is whether any of these approaches are going to give us a different type of immune system reset that may be deeper. And as the immune system resets, maybe for at least some of these folks, the antibodies are not going to come back afterwards. And so I know folks working in those areas are very interested in antibody mediated diseases, things like myasthenia gravis or ITP. But I, yeah, would argue that APS belongs in that category as we go, maybe for closer to a cure than, these suppressive treatments that we have long needed to use. And if we look at active clinical trials in the space, we do see this triangulation on B cell targeting therapies using different approaches that are not anti CD20. And so, folks can look at that table in the article. You will see that a lot of the work is happening out of China.
Hmm.
I'm involved in one study of daratumumab, which is a plasma cell depleting agent that targets the antigen called CD38 that we're about two-thirds of the way through executing. And so, I think we're going to gain a good understanding of how effective that agent is at giving us some type of a reset. So I'm optimistic. Reviewer two of the article was not quite as optimistic as I was. And so I think some of my very, just the future is now kind of comments got reined in a bit, which is probably good to find some middle ground. But I think it's an exciting time where we can begin to fantasize about giving folks their curative regimen, following them for 5 years, then finally discharging someone from our clinic who didn't either pass away or move away, right? We never never get to do this, but maybe
Right.
that's what the future holds.
Right. I mean, it'll be exciting to see. It looks like from your table and from the manuscript that there are a lot of new and exciting therapies potentially coming down the pike. So we may well be inviting you back to fill us in a little more in a couple years.
Yeah, I'd love to do that. And I do think we will have progress 2 years from now. I think that's now the kind of pace we're at. That's what I try to pump my patients up. That I am pretty optimistic we're going to have treatments that get closer to the source. No more of this blood thinning medication as a band aid, but true definitive treatments.
So, as we wrap up on the discussion of this case, can you tell us what happened to the patient you presented? And then, kind of, what do you see as the next opportunities for the field?
Yeah. Unfortunately, she has continued to not do so great. You know, with courses of rituximab. That, along with steroids, is what we use to get her alveolar hemorrhage under control, and that did seem to work. If you biopsy those folks, you commonly find a capillaritis, like there's an inflammatory process that's happening, and we were able to push that down. The disappointing feature is, though, now we are giving her regular rituximab, and despite that, her kidneys have continued to worsen to the point that she is now approaching probably needing dialysis versus a transplant. These are very difficult patients to transplant for a variety of reasons, not known to have the best outcomes. So there's always some hesitancy there. So that's what we're trying to figure out for her. This is someone that it feels like we did the right things kind of along the way. Even that first decision that I wasn't involved in when she had a DVT at 19, I mean, she then did well for another decade without any medications. I mean, it's hard to argue that was the wrong decision to make. But since the APS became apparent, she's been on all the right meds and still her body has continued to let her down. So, I mean, it's hard to, I can tell people I'm the APS expert, and she rolls in and says, "Well, what have you? What are you showing me? It's things are not going well," and that is really motivating to do better. I think the thing I'm most excited about is where we're headed with deeper B cell depletion, with the hopes that this may be the trick that we've needed. But I also think there's going to be opportunity for a lot of progress. I mean, and this is true for all rheumatic diseases, but the personalization, how to better and more smartly subgroup these folks to get away from that reactive medicine that we're so often doing, but to have a more cogent, be like the cancer doctors where you break it down. It's like, these are all the aspects of your tumor we now understand, and that points
Mhm.
us in this very precise direction, where I can quote you some numbers on, how we can expect things to go. And we're still using a lot of kind of trial and error in rheumatology that we can hope will soon be replaced by proactive personalized medicine.
And do you think that there might be an chance of net busting therapy at some point in the future?
Oh, yeah, that's an interesting thing to think about. Because, right, you go to the pharmacy, you're like, give me your best anti-neutrophil drug. And it's kind of like one drug, and it's colchicine, and that's all we have. There's some Yeah, it's probably beyond the scope of this podcast, but yeah, there's definitely other ways we could think about both preventing net release. We're interested in some agents that might be able to be repurposed. I can just throw out one that's a little random, but maybe interesting to people. One is disulfiram, which people may know its trade name in the US is Antabuse, and it has found kind of this clinical use where one of its side effects is it makes you flush and feel very badly if you consume alcohol while it's in your system. But it turns out it's also a pretty good inhibitor of this inflammatory factor called gasdermin D. Gasdermin D is best known for its role in pyroptosis, but is having an increasingly recognized role in netosis. And we have some pretty interesting data to suggest that yeah, disulfiram could be one good way to prevent APS netosis. As
Super
long as people
fascinating.
abstain from alcohol while taking it. But get money to do that study well, it's not so easy, these repurposed drug kind of concepts. So that's what we're trying to figure out as we have more and more ideas how we may be able to tune neutrophils. We know we can't deplete them like it's a CD20
Mhm.
positive B cell. That's not going to be a winning strategy to make someone neutropenic. Yet we need to turn in the volume at least a little bit. So disulfiram, there's one.
Very interesting. I'll kind of look forward to chatting to you about that at some point in the future. So, I wanted to take a few minutes now and discuss your career a little bit, if you don't mind. You grew up in
That
a
sounds embarrassing, but we can try it.
well, so I did a little bit of research and discovered that you grew up in a small town called Somerset, Indiana. And by small, I mean tiny. Its population is around 350 people. Tell us about your journey from Somerset into medicine and ultimately landing at Michigan.
Yeah, that's nice of you to do that research. Yeah, before we started recording, I was telling you how I recently went back to my old high school and gave them a speech and talked about some of where I grew up. And I did post that speech publicly. So it's nice that you found that and got to learn a little bit about my background. Yeah, Somerset, very small. I grew up in a rural county in Indiana where it was, blue collar and farming. My parents were school teachers, and we lived in kind of along State Road 13. You look to the left, and there was Somerset. It was a no stoplight town, but there was a mini mart that had a little gas station. A great place to ride bicycles, though. Remember, this was the 1980s, so it's basically like Stranger Things, which is set in Indiana, I believe. Out there riding bikes somehow for 16 hours a day in the summer. And then as my brother and I got a little older, we launched what kind of became a low key lawn mowing empire. So it was a great summer job, but then we would return to school and we're like mowing with headlights some nights to get everything done. But, so from a very young age, I got the experience of working for other people and sometimes having them criticize you when you didn't do the work quite up to their standards and then redoubling your efforts to never have that happen again. So I think lots of nice primordial experiences there. Despite it seeming like a place that might not have this, it did. And this means I was lucky to have really great science and English teachers, I think, in particular. And just, yeah, I think these were people that saw that maybe it's the kind of place that there's a good chance that's where you're going to kind of hang out long term. But kind of pushed me to think, now I still needed some more pushing because when it became time to apply for college, I applied to two schools. Ball State, which is the main place if you went to college from my high school, you mostly went to Ball State, David Letterman's alma mater. And then I applied to Indiana University in the southern part of the state. And that's where I ended up going. And it was a big school, but kind of had everything. And that's really what I needed to meet professional scientists, which is certainly not something I had done as a kid. But then I made another leap of faith because, IU's undergrad campus is not affiliated with the medical school. So, there wasn't really biomedical research happening there the way it happens in my lab at University of Michigan now. And so despite never having met anyone with MD, PhD training, I decided that that is what I should do. And so that was another leap of faith. I had not been on an airplane until I applied for, it's a little embarrassing, but until I applied for medical school. So the thought of going somewhere that I couldn't drive back home to Indiana when I needed to, it just didn't seem possible. So, I applied to schools in the Midwest and I was lucky to eventually get in off the waiting list at Michigan. And the rest is mostly history. My PhD advisor during the PhD phase of my training took a job in Philadelphia, so I moved there for 3 years
Oh, wow.
before moving back to finish medical school, and that was a little bit of a jolt for my partner, now spouse, and what she was dealing with. And so, I kind of settled at Michigan for a while, and now I've been here ever since.
And I hope that at some point you've had a chance to tease the dean about having been waitlisted for admission.
Well, I was down on the wait list, but yeah, I don't think I framed myself. I didn't have a lot of coaching. I mean, I see how it is now. Like these med students are they just know everything about, what should be in their personal statement. I mean, I had written a personal statement, and because it came full circle, I thought it was good. Like I started out talking about small town, but then I kind of ended, maybe I'll end up back in a small town. I'm like, oh, this is a good, device for my write up here. But I mean, I heard after the fact that that raised some red flags. Like, is this because they dread the MD PhD applicant who's going to immediately drop out after getting a couple years of free med school and go the purely clinical route. So I think I shot myself in the foot in some ways, but it all led me to my job now. So maybe meant to be.
The universe took care of you. That's
Yeah.
all I can say.
For once, the universe had my back.
So you are a physician, a scientist, a husband, a parent of 2 children, chief dog walker for Sparky the Beagle, who can be found lighting up your social media. How do you balance all these competing priorities? And do you have any tips for finding more hours in the day?
Yeah, thanks for that question and for the shout out of Sparky the Beagle, who is, truly one of my best friends. You can't spell Sparky without APS, as we sometimes say. And indeed, he's a little bit of a mascot for our APS program. If folks find our lab website, which is pretty easy to find, and sign up for our newsletter, my daughter writes a column about Sparky's hijinks that you can read every couple months. He's usually up to something, and if you want to read about that, that's the place to do it.
I love it.
But yeah, I mean, yeah. So what you really asked me though is like, what's the life hack that I figured out to make things doable? And I'm still trying to figure that out. I suspect you've asked this of other people. Maybe you and your team can put all those responses together into a single podcast that we can all listen to. And maybe somewhere in there is the secret for each one of us. I mean, think one concept is that most things do pass. I just remember, I mean, for me, it was when I had little kids and just the extra pressures that puts on you. And it's just so challenging. And there may be someone listening to this in that time now. And I mean, certainly other challenging things arise, but I try to remind myself of that if you're going through a tough stretch. Often, I mean, and sometimes that's measured in years, not weeks or months, but it typically will get better. And then I think I've just tried to, cliche alert, control what I can control. I mean, find things in this wacky thing we do where you can kind of stick to what matters to you. One thing for me is, I guess going back to when I've always had jobs, is like I'm someone that wants to be the first person on my team to work. And that's something I've always tried to do. And, something I've maintained. Now, like, what's it mean if I were to roll into my office and I see someone already working in the lab? They must be even more motivated than me. And I don't like to feel that way. So, that's not the trick for everyone, but maybe finding some tricks that you can be consistent about makes you feel like you have a little more control as you navigate this. But it's not easy.
Yeah. So I'm going to kind of twist that question around a little bit, because from the outside, it seems like you're successful in everything that you do.
LOL.
But I'm going to ask you, can we dispel the myth? Most scientists have had setbacks. I'm sure you're probably no exception. I'm wondering if you'd be willing to share any failures and how they shaped you.
You ask the question like that, but do you ever ask it and someone is like really unable to generate anything? Because to me, it feels, I mean, I don't know, at least as a scientist who submits grants, and I've had an especially bad year with those, maybe going from July right up until today, where the one I had the most optimism for was a resubmission. I think it's very good. It got a 9th percentile. Of course, NIAMS pay lines are nowadays at the 8th percentile. So my last hope for the academic year maybe has passed. But I mean, yeah, at least 10 unsuccessful applications. Each of these you end up spending a month on, and it all just kind of disappears into nothingness. So I could spend a lot of time going through each of these and just showing the amount of time that went into them that kind of led to nothing. So I'm not sure if there's a lesson in that except having a high tolerance for pain. But
and it's not nothing, right? Because you always rework them.
Yeah, yeah, maybe. I don't know. Yeah. The longer I do it, though, you just see how arbitrary it feels. Like I used to try to find the clue to like what led to this grant getting funded and this one not. And yeah, I don't know. It's something I've been able to do for now. Can I do it for another 20 years? We'll see. So if someone out there is thinking I'm successful at everything I do, just know that many days like today, I think, geez, can I do this for another month, let alone a few decades? But on we go.
Yeah. And you're motivated, I'm assuming, by something bigger than the next grant, right? Because if you were just motivated by the external.
Yeah, the personal glory of the physician scientist.
It wouldn't work.
Yeah, you're right, though. I guess that is why you keep doing it, right? Because you see this unmet need. But I remind myself, I think I'm just going through a relatively harder stretch, and it probably will also pass. So, yeah, I think that's what we fall back on.
I will also point out that you have particularly had some banner years. So, so I'm going to thank you. This was a terrific conversation. I appreciate you sharing all of your wisdom and your experiences, good and bad. I think it's just great for our listeners to hear what it's really like.
Thank you.
Thanks today also go to all scientists who toil at the lab bench, one experiment at a time, enduring failures to make incremental advances for people living with complex autoimmune diseases. We are so grateful that you do this work. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRoom on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.